Hello, everyone, and welcome to our information session regarding the launch of the practice standard for supervision of occupational therapist assistants. First, I'd like to introduce the staff who are presenting today. We have Naz Chow, practice advisor, and myself, Megan Shields, deputy registrar. And a quick note before we get started, it may be helpful to have a copy of the standard available as we go through this presentation. I'm excited to present today's agenda, which focuses on the launch of the practice standard for supervision of occupational therapist assistants, OTAs. We hope you walk away from this session with some new information and find the content helpful. We will dive into how the standard came to be and review the consultation process we went through to get to this stage. A significant part of our discussion will be dedicated to comparing the previous guideline with the new standard, emphasizing the main changes and their implications. And before we move further, I'd like to acknowledge and express gratitude that the main COTBC office is located on the traditional territory of the Wasanich peoples, including the Powkachin, Sayout, Sartlip, and Saycum First Nations, who've had a special relationship with this land for thousands of years. As part of the development of the standard, we went through a multi-step process. I'd like to express appreciation to all the people we consulted to develop this practice standard. It wouldn't have been possible without the feedback from various occupational therapists, professional practice leaders, and subject matter experts within the field, from an array of geographical locations, encompassing both health authorities and private practice organizations. Of significant importance, I'd like to recognize Helen Turner, independent occupational therapist from private practice, who supported us to draft the first iteration of the standard, and Heather Gillespie, instructor for the online therapist assistant education program through Medicine Hat College in Alberta, who offered many hours of her expertise to get the standard to what it looks like today. The next round of consultation included seeking Indigenous perspectives to inform the practice standard, with the intent of eliminating harmful practices and removal of colonial context and wording. For the first time, COTBC utilized our registration data, where registrants had the option to consent to being contacted by the college for regulatory-related issues as a self-identifying Indigenous registrant. This was an exciting step as we continue to work towards our ongoing commitment and action related to cultural safety and humility and Indigenous anti-racism practices. Both the Patient Relations Standards and Ethics Committee and the Quality Assurance Committee reviewed and provided feedback on the practice standard. The Case Development Subcommittee contributed many hours towards the implementation plan of the standard, with developing case scenarios to support the standard as a practice resource. And lastly, we had legal counsel review the standard, and their recommendations were incorporated into the final document. It was a milestone achievement, an important step to revise the practice guideline for supervising support personnel to the practice standard for supervision of occupational therapist assistants for multiple reasons. The practice guideline from 2011 was the last guideline converted to a practice standard. From a regulatory perspective, a practice guideline is not a must-do document, whereas the intent of the practice standard for the purposes of public protection is to outline the registrant responsibility and to clearly identify the baseline expectations for OT practice. Clinical practice, as it relates to the supervision of assistants, has evolved significantly since 2011, and our new standard reflects these changes. For instance, we revived the definitions section to better reflect our current legislation and clinical practice in today's context, including the evolution of virtual care and remote supervision as an option within the definition of supervision. We've also made a significant shift in terminology, moving from support personnel to occupational therapist assistants. This will be explored in greater detail in upcoming slides. Essentially, our goal with this transition is to provide clarity and consistency of roles of occupational therapist assistants across Canada. Naz will speak more about each of these factors in a moment, and I will speak to the high-level differences between the guideline and the standard. For instance, for practice expectations. Within the guideline, the expectations for OTs were brief and lacked explicit examples. The new standard emphasizes OT accountability throughout the standard, specifically regarding determining the competency, abilities, skills, and knowledge levels of OTAs. This would then influence the type or complexity of the OT service components being assigned to OTAs. It requires the OT to be self-aware of their own competence before any consideration is made as to what could be assigned to an OTA. This is highlighted in the first standard regarding accountability. Exceptions to the rule. The old guideline did not outline exceptions for support personnel use. The updated standard clearly outlines exceptions regarding OTA roles in context to today's clinical settings. Decision-making tools. The previous checklist table was 2 pages long and did not include cultural safety in the listed risk factors. Now the checklist is simplified and the risk tool is updated with expanded risk factors, placing the client at the center of decision-making. It aligns with the competencies for occupational therapists in Canada. This comparison illustrates a move towards more detailed and specific standard requirements, enhancing clarity and accountability in OT practice. And with that, let's discuss the significant transition from the term support personnel to occupational therapist assistants, or OTAs. This shift is more than a change in terminology. It represents a move towards greater clarity and accountability across our profession nationwide. Previously, support personnel was a generic term that lacked clear accountability and role definition in relation to occupational therapists. The introduction of OTA addresses this by providing specificity, highlighting the assistant's accountability to occupational therapists and the supervisory role that the occupational therapist holds. Another important note, adopting OTA aligns us with other Canadian OT regulators, partners like the Canadian Association of Occupational Therapists, and bodies involved in OTA education and accreditation. This alignment supports a unified approach to occupational therapy across Canada, benefiting OTs, assistants, our clients, the organizations with which we work, and the overall professional standard we have for supervision. In essence, this title change strengthens the professional relationship between OTs and their assistants and reaffirms our commitment to excellence and clearly defined roles in client care. Pulling from the definition of OTA, we purposefully did not create an exhaustive list of job titles. We know that job titles vary, and there are many iterations that exist from context to context. Within the OTA definition, when an assistant, regardless of their job title, has been assigned to deliver components of the OT treatment plan, they are acting as your OTA. And here is a list of what some of those potential job titles could be in your practice. I will now pass it over to Naz, who will highlight some of the key elements that have been updated within the standard.
Supervision has a focus on the interactive nature and continuous working relationship with the OTA. There is direct guidance and responsibility for accountability and feedback from the OTA with expectations to meet timelines, goals, and expectations, whereas consultation is different. The OT may be called in to support a client's treatment plan by providing expert advice to, offering education or training for, and/or facilitating problem solving with another service provider or other personnel. For example, the OT does an in-service on proper inflation of ROHO cushions and checks and sets up a checklist for staff to follow. Nursing staff ask for suggestions regarding managing the transfer needs of a client. In this instance, the OT does an in-service with staff specific to transfers for that particular client. The OT is responsible for the quality and appropriateness of the recommendations, but not for the ongoing competency, behavior, or quality of service of the other service providers or personnel. Moving on to what supervision entails and the focus on accountability. Section 1 of the practice standard says, the OT will be fully accountable for all occupational therapy treatment components that they have assigned to an OTA. For example, 1.2 of the standard speaks to application of continuous clinical decision-making and risk assessment. Section 1.3 speaks to a treatment plan. As mentioned on the previous slide, the treatment plan has clear timelines, goals, and expectations of assigned components. Exceptions where supervision does not occur are outlined in sections 1.10 with subsections 1.101 to 1.103. In some settings, OTAs may be required to perform additional tasks that do not fall under the occupational therapist's responsibility. These exceptions include 1.10.1, delivering services that are within their job duties but are not part of an occupational therapy treatment plan. For example, an exercise group or a recreation activity as part of the overall programming offered at a facility. Such an activity is not part of the occupational therapy treatment plan for a particular client. However, it is included within the overall services offered at a facility. 1.10.2, the OTA is working with other regulated health professionals. For example, carrying out a walking program by a physiotherapist. 1.10.3, administrative activities assigned by their employer. For example, updating the inventory of equipment in a storage room. Section 2 of the practice standards outlines specifics around the identification and selection of treatment components that may or may not be assigned to an OTA. Examples of tasks that will not be assigned to an OTA are clearly outlined in subsections 2.6 to 2.14. These examples include interpretation or screening or initiation of a referral, assessment, treatment requiring dynamic reasoning, for example, advanced cognitive retraining, analysis or interpretation of assessment findings, referrals to other providers such as the physiotherapist, the social worker, or a counselor, discharge planning decisions, for example, readiness for discharge or date of a discharge, and finally, outcome evaluation of a program. The purpose of updating this checklist in Appendix A was to provide registrants with a standalone document to support the decision-making process around assignment of tasks to OTAs. Assignment to an OTA occurs when all questions are checked. Starting with question 1, if the treatment component is not within OT scope of practice, then there would be no assignment to an OTA. Hence, you would not go any further. Then the OT would move on to Question 2. Assess self-awareness of their own competence, and so on through each question in the checklist, down to development of a treatment plan, and finally, outlining documentation expectations or reporting back mechanisms. The visuals of the risk management tool have also been updated to reflect a modernized look when evaluating the risks associated with assigning tasks to OTAs and the level of supervision required. Lastly, there is a queue for consideration of when the treatment plan may need to be revised or updated. We've changed the look of the risk management tool to emphasize the client-centered principles of OT practice. The client is at the center, with the OT risk factors and decisions related to assignment of components at the top left and right, followed by the environmental considerations and the OTA's competence on the bottom, right, and left, and they're all interconnected. This concludes the presentation of the practice standard. References are available on the last page of the practice standard for your review as needed. If you have any questions after viewing this recording and reviewing the practice standard, please do not hesitate to reach out to either Megan or myself and the rest of the team here at COTBC. We can be reached at info@cotbc.org or practice@cotbc.org. Thank you.